I am Dr. Chawla from Kanpur. At the outset, I would like to congratulate Sandip Pal and his team for the kind invitation. And today, I am doing one case here. She's a 24-year-old female, is on PPI since last 2 years, and she has been PPI dependent. Of PPI, there was a esophageal 24-hour pH impedance done, which showed a significant increase in acid exposure time to the tune of 57%, significant D-Mister score, and manometry also has been done, which has showed normal peristalsis. Previous scopy has showed a EJJ morphology of type A EJJ morphology on manometry. So my job today is to do a procedure of ARMA, anti-reflux mucosal ablation, and to guide me is Jayanta, Samanta, my dear friend. So
Hello.
Together we'll be doing this procedure. So the history of ARMA goes back in 2014. Initially, Haru Inouye, which we all know, who developed POEM, he started doing mucosectomies, EMRs at the LES, and he found that such patients were getting, especially for Barrett's, he started doing EMRs and ESD at the LES area, and he found that their GERDs were improving. Then he did a pilot study in 2014. That time he was doing mucosectomy, means he was doing a snare and doing a EMR or ESD, but that procedure, as we were doing EMR and ESD of that area, there were complications of bleeding and perforation, and it's a benign disease. So in 2020 he again published a pilot study of 14 or 20 patients, in which again he did manometry 24 analysis, who were classic refractory GERD patients. They did for refractory GERD rather than PPI dependent GERD, and they found that this procedure, in which they were just ablating the layer of mucosa and deep mucosa, and then healing occurs, scar forms at the GE junction.
That will cause a tightening
of the LES and this. So we also have been doing since past 5 years this procedure, but this procedure only to be done for PPI dependent GERD who wants to get off PPI, or PPI refractory GERD, and they should be documented GERD on 24-hour pH analysis, and manometry also should be done to assess the peristalsis. What's your experience?
I think yes, that's correct. We need to kind of have a as Gaurav was telling, we need to have a pre-procedure kind of proper evaluation, which consists of 3 components. One is an upper GI endoscopy to kind of identify the type of Hill's grade that we have.
So here we can see it's almost normal of. So LA grade C and grade E are contraindications for endoscopic management of GERD. So it's pretty normal here. You can she fits into the criteria.
So it has to be primarily what we say is at least a Hill's grade 1 or 2, followed by a normal HR manometry showing that the esophagus is functioning normally.
So it's a very good case. You can see it's almost a grade 1,
like
class
a Hill's grade 1.
Grade 1. So it's ideal case for ARMA, young female. So I distinctly remember one of my patients who young, similar to age, who wants to get married, and she didn't want to continue PPI.
Right.
So now what we are doing today is first.
So you helped her get married. Fine.
So what we are doing is technique which we are using, we'll inject saline or indigo carmine just to at the G junction area, so that it will increase the safety of the procedure, and because once we give the argon gas to that area, it can go more deep and cause muscle injury.
Late perforation and bleed can happen.
So to make it more safer, we'll be injecting this with now I'm using a 23 gauge needle, and my assistant just hold the scope like this.
So usually kind of the dictum is it will be almost circumferential ablation except for one scope gap along the lesser curvature. Second will be around a one scope gap distance from the Z line.
That's very important point which Jayanta has said. It should be one scope line. Otherwise, if we have involved the GE junction, it can cause stricture and dysphagia. Only problem with ARMA is that it can cause stricture if we are not cautious.
Careful enough. Absolutely right. So what Dr. Gaurav is now currently doing, as you can see, that he is injecting, lifting the submucosal space, and then kind of it gives a cushion, as you had already mentioned, and kind of makes the procedure slightly more safer. Although you can do it without the injection also as well. It depends on your kind of personal preference and practice.
So I think this is the last injection
Yes,
which I am
yes,
giving.
yes. I think it's okay.
Inject. Okay.
Right. So we're okay with this.
Yeah. So
Yeah,
we
you
have
can see how
injected.
nicely it has been kind of circumferential elevation has been there, and so now we proceed with the ablation.
So here we are using Arbe APC post pulse, and the setting which I have told them is we want a 80 watt setting.
Yeah.
And flow rate of 1 liter per minute, which and we are using a forced APC in this case. So what our aim will be to do in a horseshoe shape pattern.
Yes, yes.
2 horses will be like that 1.5 times the scope diameter, and then one will be 1 time the scope diameter.
Yeah.
And we'll leave the area just along the, as he told, along the lesser curvature.
Yes. So we'll keep on doing it now. So you can see over here, we are doing a standard APC. So this is a very relatively very easy procedure for persons. Only caveat is that what, as Dr. Gaurav mentioned, that you need to be careful about how the technique is being done, because, right, Gaurav?
Yeah, absolutely. So see, I am not touching it. We have to, as like principles of APC we use in Antrum, it's a non-contact technique.
And you can clearly see as how Gaurav is doing that you need to do a broad band of APC. It's not like a
patient is moving.
It's not like that you do a simple, a single strip of APC. It has to be, the width is usually, again, the same principle. The width is actually around 1 to 1.5 times the scope width. So that is the width of the APC that you do. Otherwise, you will not, get that much amount of fibrosis to help the patient.
So I am leaving this much space.
Yes. As you can see, Gaurav has left a space of around 1 scope position in this part. Because if you do a circumferential one, what can happen is, because of the scarring, you can develop stricture. So that is the reason why we usually leave that part. So we do not go close to the Z line. We stay away from the Z line and keep ablating. Yeah. As you can see, Dr. Gaurav is doing. Yeah, very nice. So Gaurav has a trident of Zeus, it seems, with lightning bursting through the G junction. Can you see? Yeah.
So relatively, we can finish in 10 to 15 minutes.
Yes, it's a very relatively easy procedure. And but obviously we need to kind of.
But case selection should be proper.
Yes. So that's what I wanted to kind of mention, that obviously the case selection, the caveats, where to do, where not to do, and how to do are the things which are kind of makes it more important.
So now the problem I was asking, that this procedure is whatever data we have in GERD management for endoscopic, it is a very short-term follow-up. Whatever therapy they have used is for 1 year. Data has shown, INOI has shown that 1 year we should tell our patients 70 to 90% relief will be there for 1 year. So upfront we should tell them, although this procedure can be repeated also safely.
Yes.
After 1 year.
So that's the beauty, that we can kind of easily.
And it is not very costly as compared to the other endoscopic.
Yes, absolutely. It's way cheaper than GERD-X, and I think we will do some part over here. This part, I will slightly widen it out. Yeah, this part. Yeah. Very nice demonstration. One more thing we have to be very careful is when you are doing a retroversion and kind of burning these things, you have to be very careful about the scope as well. So you do not cause inadvertent injury to your scope shaft, because then it will become a costly procedure.
So what do you think, then? So are we done?
I think we are done. It's a very nicely done job. I think we are done. Yeah.
I think these are the horseshoe shape. These are the two.
Yes, absolutely.
This and these are this.
Yeah. Very nice procedure. Thank you. Excellent.
Thank you.